Hi, my name is Armin Mirzayan. I'm a dentist practicing in Los Angeles. I'm also the co-founder of the website cerecdoctors.com and a faculty member of the Scottsdale Center for Dentistry, the CAD/CAM division. I want to share with you my excitement for Cerec. I've been a 10-year user, 11-year user, and I really want you to be aware of all the different things your machine can do for you. We're no longer limited to just single unit restorations. We can do multiples. We can design opposing restorations at the same time. We can manage anteriors. We can fabricate surgical stents that we can place implants in the ideal position that's prosthetically driven. First thing I'm going to do right away is take you through a single unit restoration, how simple it is, and we'll expand on that, get into quadrants, anterior cases, much more difficult cases, and then we'll get into some implant planning stuff as well. So here we have a patient who needs tooth number 3, the upper first molar, treated with a full coverage crown. It's a failing amalgam that has recurrent decay. And as soon as I remove the anesthesia needle, I'm going to go ahead and have the patient bite down into maximum intercuspation. Then I'm going to go ahead and dust the area, and what we're capturing here is called a buccal bite. The buccal bite allows me to relate the upper jaw to the lower jaw when I'm designing the restoration. And you're seeing this captured live. That's exactly how long it takes, maybe 10-15 seconds at the most. Then we're going to place the isolate device that gives me good isolation, suction, retraction, and a bite block. And we're going to isolate the opposing dentition in this case, the lower arch. I'm going to go ahead and dust this area as well. I'd like for you to see exactly what this entails clinically. I'm going to dry the area real quick, and we're going to spray some powder. Really, that's as involved as it gets with powdering. Now we're going to place the camera in the patient's mouth, and I'm going to scan from the second molar on forward. If your camera shakes at all, if there's any movement, it will not capture the optical impressions that you're seeing on the right side of the screen. As soon as I hold steady, the camera captures the optical impressions that I need, and it renders a 3D model on the right side. So this is pretty quick. Scanning the second molar to the canine, this lower arch takes maybe about 30 seconds time, and you do want to hold nice and steady and let the auto capture take effect. Now, by this point, the patient's nicely anesthetized. You can see the decay under the mesiobuccal cusp. I like to use the occlusal router and create my troughs and channels and follow that with a flat disc. What this lets me do is reduce the cusp tips and make sure I have enough reduction. Then I'll take my shoulder burr and do my axial reduction and remove the remaining amalgam from the central groove area. The very next thing I'm going to do, just like PVS impressions, it's absolutely essential and critical that we get soft tissue retraction. Here I'm using a laser. You can certainly use cord, but laser affords me a great luxury because I have no bleeding whatsoever. I get hemostasis right away, and I completely displace the tissue. It's absolutely imperative that we can clearly see where the margins are so that we can deliver restoration that fits perfectly. And the laser accomplishes that for me very readily and easily. If you've never seen a laser in action, this looks horrific to you, but it heals very, very nicely just within a few days' time. There's very minimal, if any, post-op discomfort from this. So we've got the tissue retracted, and we're going to go ahead and dust the area again, and we want to make sure that we can clearly delineate where the margins are. Again, here's a bird's eye view through the Zeiss microscope for you to see exactly what I'm doing. All I need to do is mask the topography of the preparation, and I'm ready to capture the optical impressions. Now here is the number one thing I absolutely love about my Cerec machine. As soon as I place the camera and hold it still, it captures the optical impression for me, and the most important thing to me right here is that within a fraction of a second, I know I've nailed my margins. I know I've captured them. I don't have to wait 4 or 5 minutes for PVS to set. I'm not worried about any hemorrhaging because it's a very quick scan. I know exactly where my margins are. I can verify it and validate it, and I'm ready to move on. So again, this whole process may be 30 seconds of my time, and we're capturing the canine over here so we can articulate that buccal bite to the lower model and the upper model. We'll proceed to the very next step by clicking on the Model tab where the software is cleaned up, any artifact is removed, and we get very nice models rendered. Here at this step called the buccal bite, we're going to relate that relationship. We're going to take that gray model, which was the buccal bite, place it on the corresponding teeth in the upper model, and then we're going to drag this whole complex down and articulate them together. Now, what's really cool about this step, again, with digital impressions, there's no artifact, there's no distortion, there's no elongation or anything like that. And I can click on that analyzing tool, and those occlusal markings that you saw, I can clinically verify that it's very, very accurate. Obviously, the bite is taken in maximum intercuspation, so you will have to adjust excursives after you've seated the restoration. But it's incredible to me how precise this is and how little adjustments I need to do after I deliver the restoration. Once we've done the margins, we'll proceed to the very next step where a proposal is given to us, and this is how far Cerec has come. In the years past, we were happy to get any proposal, and we'd spend about 20 minutes modifying the contacts, the contours, the height, and the software does most of that work for us, and the remaining 1-2% of the time for the design process, it's up to us to modify to our liking. The very first thing I like to do is watch the restoration within the arch form articulated with the opposing, so I can see exactly where it is within the arch form, and I can use some very large tools like you see here. This is called a rotate tool, where I can rotate the restoration to my liking, maybe tilt it to the buccal, rotate it clockwise, counterclockwise, and get in the position that I want. I'm going to click on another feature of the Move tool called the Position tool. Now I can take this whole restoration, move it buccal, lingual, any direction that I want. The blue turquoise that you see on the palatal part of the restoration gives me a warning. Hey Armin, at this point you're under your defined setting of how thick you want this restoration. Where I see that turquoise, I'm under 0.6, 0.7 millimeters in thickness, and as you know with ceramic restorations, if it's not thick enough, it will fracture. So we have many ways to keep track of our thickness for the ceramic to make sure it's not under reduced or it's not bulky enough, so we don't get in a bind. Some other tools to introduce you to. Here's the shape tool. There's many features to it. I'm just going to highlight the two-directional view where you can take a cusp tip and just drag it occlusively or any direction you want. Let's grab the mesobuccal cusp and move it and close that diastema. That's obviously exaggerated. Just want to show you the movements you can control. And this is what we absolutely love as dentists. We love the fact that we have control over everything. In fact, what we enjoy the most about our Cerecs is having the control over our contacts. Here you see in my contact area, I can broaden the contact surface area, I can broaden the strength. Red obviously means it's way too strong. Red is an indication that you're over 100 microns in thickness of contact. So personally, I developed the contact area so it's nice and broad. Then I'll take a tool called a Form Minus tool and just dab out the red. And I want it speckled with green and yellow. That's perfect for me. One swipe of the polishing burn, I'm exactly where I want to be. I'll take the smooth tool and blend it all in so it has a very nice texture circumferentially, and we're ready for the milling of this restoration. Some other things to show you here. I'm using the rotate again to position it a little bit more nicely in the arch form. We also have a tool that allows us to shrink the crown in the buccal lingual direction or the mesial distal direction, or we can do it uniformly. So if you have a practice where you have a lot of pediatric patients, you can actually design these crowns and then shrink them to fit the arch form of a child patient. This is the dimension tool that expands in the buccal lingual direction. We can grab the multi-directional tool here and shrink the crown, and there you see the turquoise bubble again. That's my last ditch resort to make sure that I'm not reduced or under-reduced. So once we're done with the design of the restoration, we're ready to fabricate this. We'll send this off to the milling machine, and we're going to use a material called Emax, which is lithium disilicate, which has been pretty popular in dentistry in the last 5-6 years. The restoration's milled in about 8 minutes time, and I try it in here to make sure I'm happy with my contacts and my margins, and I'm ready to bond this. This is another thing that I absolutely love about my Cerec. I can essentially seal a tooth 20-25 minutes after it's been prepped permanently. I love that. I think that's the best thing for a tooth that's vital. I believe, this is purely anecdotal, the worst thing I can do to a vital tooth is place a temporary on it and then traumatize a tooth when I come back to seat the restoration. So this is one of the huge advantages of being able to mill this chairside and deliver it in a single appointment. What I'm doing here is I've got the preparation etched, prime, and bonded. I thin out the bonding agent. I don't cure it because I don't want any of that resin to pool in a corner, and I cure it. I might inadvertently keep my restoration from seating all the way. I'm using Optibond FL here. I'm going to use NX3, and I just apply this material called Blue Sep that goes on the contacts of the adjacent teeth. That does not allow my restoration to bond to my adjacent dentition. Now I'm just cleaning out the area, I'm flossing it really well, and we cure it, and we're ready to go. Let's move on to quadrants here. We have a second molar that needs an amalgam replacement. The first molar needs a full coverage crown with undermined cusp and a small inlay for the premolar in front of it. So it's a 3-tooth quadrant, and it's the same sequence here as you saw for a single tooth. Let's expand on the software. Here's where in the administration tab where you choose which teeth you're working on, what kind of designs they are, what type of material you're going to use, and if you happen to have multiple milling machines, which milling machine you want to send it off to. So same sequence as a single unit here. We're going to go ahead and anesthetize the patient by giving her a block anesthetic, and we'll have the patient bite down to maximum intercuspation. So the routine is good for you to see. It's the same sequence every single time. We're going to go ahead and dry the area and powder as well. And the whole reason we powder is because teeth are like ceramic are like glass, and they absorb, reflect, refract light. And by dusting the area with that powder, we keep the light from penetrating to the tooth structure and being absorbed and reflected. And we place the medium on top of the teeth, so when you scan it, you pick up the true topography and the morphology of your tooth or your preparation. So here's the buccal bite. You see 3 folders at the bottom of the screen. That's going to help me relate the upper jaw to the lower jaw. Again, same sequence of events as you saw for single unit 1. We're going to go ahead and place the isolite in the patient's mouth. And now we've got good retraction of the tongue's not an issue. We've got no worries about the humidity in the patient's mouth because the suction's taking care of that for us. So once I've got the area nicely isolated with the Optragate and the isolite, 2 separate products, I'm going to go ahead and powder the upper dentition. Now most practitioners have their team members capture the buccal bite and the opposing. They just approach the patient with a preparation. Once the preparations are done, they'll go ahead and image the preps. Here you can see how easy it is to capture the second molar once I've got the retraction. I'm going to be occluding with that second molar, and if you notice here, I didn't capture the whole tooth, so I'm going to go a little bit more distally and capture the marginal ridge because I want to see exactly where my designed restoration on that second molar is going to be contacting the opposing. So any areas you don't capture inadvertently, you can easily go back with the camera and the software and fill in areas that are missing. And again, I scan from the second molar to the canine because I want to see exactly how these restorations will fit in the arch form. We're ready to proceed to the next step. The patient's now at this point numb. Again, that whole process of the buccal bite and the opposing, to give you a perspective, takes about 1.5 minutes to do, which is just the perfect amount of time for the patient to get numb. And I'll start with my router burr again. The router burr assures me that I've got enough depth reduction, and from there I'll switch to my flat disc. From here on out, I'm going to clean out any of the remaining amalgam and reduce the cuss tips so that I can have uniform thickness of about 1.5 to 2 millimeters for my ceramic restoration. Once I've removed the occlusal table, essentially, it's a lot easier for me now to use a shoulder burr and reduce my axial walls, because I've got much easier access to the prep field. And it really speeds up the preparation. If I start in the other sequence, I'll struggle with the axial reductions because I've got a large, tall occlusal table. So here we are with amalgam restorations removed, and we have an inlay prep for the distal second molar. You can see the hemorrhage, the bleeding as soon as I removed the amalgam. One of them had a big overhang, and I knew we were going to get some bleeding from the tissue. And here you can see the crown preparation for the first molar. Now, on a vital tooth like this that doesn't have a pre-existing restoration or pre-existing crown, I always leave my lingual margin high above the gum line because I've got a nice band of enamel to bond to. Inspecting for recurrent decay is easy. The patient can keep the area nice and clean. And I prefer that over hiding the margins of a metal restoration like a PFM. Again, here you're seeing the Odyssey laser from Ivoclar. It's being utilized to get the tissue retraction that we need and the hemostasis that we need. Here's our prep form, and again, no matter what I see clinically, even though I'm using a scope, it's really humbling the first time you use a Cerec machine to see your preps blown up 25-fold. So I pay extra special attention to make sure all my walls are divergent on that inlay restoration, and that I've done a good job getting enough retraction, and I've done a good job displaying my margins. We'll go ahead and powder this area, and I'm going to take a quick look with my mouth mirror to make sure I've got hemostasis and that my margins are readily visible. And let's zoom in with the scope, and I can clearly see where those margins are. That makes life very easy when I'm doing the restorations, makes it very easy to try in, and while I'm bonding as well. So we'll go ahead and scan this quadrant. We'll do it all at once. So we'll turn on the camera, and again, as soon as I place the camera in the patient's mouth and I hold still, my optical impressions are going to be captured. I'm going to position the camera in such a manner so that I can see all my walls drawing and flaring together. As soon as I hold steady, we'll capture a 3D model on the right side of the screen. Move on to the crown prep, and again, I love this. Within a split second, I know I've got my margins and I've captured them. I don't have to worry about any bubbles or any tearing. In fact, quite honestly, I've completely lost the skill set for taking PVS impressions. It is the most annoying process for me clinically. It just drives me absolutely crazy to wait 4 minutes to see if I captured my margins. So I love this part about Cerec. We'll click on the model step. Now you're familiar with this, and we get the 3 models rendered, and we're going to relate the buccal bite to the upper jaw. We'll just drag it. Here I'm going to drag it to the lower jaw, and I left this in here for some comedy's sake. I can't get the buccal bite to articulate because simply I made a very inadvertent mistake where I keep dragging the buccal bite to the wrong teeth. So I'm essentially recording exactly everything I'm doing live. It takes 3 or 4 attempts for me to figure out, hey, I'm actually placing it on the wrong tooth. So I left it in there for some humor. That's where it belongs. And now you can see the buccal bite vacuum sealing itself onto the correct teeth. We'll relate the models to each other this way. And now we have a very precise record of how the opposing arches articulate together. Now we're ready to proceed with placing margins on these 3 restorations, or these 3 preparations. You'll see at the bottom of the screen we have some teeth highlighted, 18, 19, 20, the premolar and the 2 molars. I've edited this for time's sake, and I've placed the margins on the first molar. We're going to go ahead and delineate the margins for the second molar, and you want to make sure you don't fall off any tooth structure, and you've done this correctly. What's great about the biogeneric software, which was introduced to the Cerec world just a few years ago, the biogeneric software does a lot of math for us, where it takes the adjacent teeth into consideration, the remaining tooth structure into consideration, to give you the most ideal proposal that's based on the remaining anatomy that's intact. So the proposals that are rendered are very much lifelike, and they reflect exactly how it belongs in the arch form, and particularly for partial crown restorations or inlays, gives you a very, very nice morphology. So all 3 restorations here are now proposed, and now one of them still being proposed. I can work on the first molar while the second molar is being rendered. All 3 of them will render at the same time. Again, you're familiar now with the position tool. I'm going to move it into the arch form, position it to where I want, and go through all my different tools that I need to perfect this proposal. And you can work on each one of the restorations on an individual basis. So I'll broaden my contacts here, close the diastema on the mesial of the first molar. My occlusion's too high, so I'm going to use the shape tool again to uniformly reduce the size of the cusp. And there's many variations to this. You can use a 2-dimensional tool just to get the restorations in the perfect occlusal scheme. Now for me, in my machine, in my hands, I want very little color. In fact, I want it to be in dark blue, and I have very minimal post-op adjustments to do. So we'll go ahead and send the first one to the milling machine, and while that's milling, we'll refine the preparation or the restorations for the other 3, for the other 2 proposals, and mill those as well. Now personally, I've been at this for a while. I have multiple milling machines, so I can speed up the time even more by having the multiple milling machines manage the multiple restorations. Now we're ready to bond all 3 restorations. This whole process took me about 2 hours time to do 3 indirects on the lower arch. We're going to go ahead and load the preparation for the second molar, which is an inlay. I've got the area etched, prime, and bonded, and I'm going to seat the resin cement. This is Optibond FL like the previous case, and I'm using the NX3 resin cement. What I love about the NX3 resin cement is that I have 90 seconds of working time. So once I seat this restoration, I can clean up the mesial, the excess resin that you see there, and then load more resin from the same compule onto the first preparation. So we'll clean this up. I've got all the time in the world. I don't have to worry about the resin setting prematurely for me. And once I've cleaned up the mesial of that area, I'm going to go straight to the first molar. And like I said, from the same cartridge that I dispensed with the first preparation, I'm going to continue loading it onto the second preparation. So we'll go ahead and seat this crown as well and start the cleanup process. I like to clean up as much as I can so that the resin has been removed before it's set. Once it sets and once it's cured, the task of cleaning up the resin cement infinitely grows higher, so it's much easier for me to remove it in this state. In fact, when it gets to the gel set stage, it's even easier to pick out the excess resin, get it out from the contacts. Once I've got the mesial cleaned out of that first molar, I'm going to go ahead and load the small premolar inlay prep, add a little bit of the resin cement, and go ahead and seat that final restoration. Once that's seated, I'm going to go ahead and floss the areas before we even tack cure this. The worst thing I can do is cure these restorations prematurely and not verify that they've seated all the way. So I'll do all the verification. Now I'm going to clean up my contacts here, and this is absolutely imperative that my assistant does not let me floss until she has a good grip on the restorations. This is the Reach Floss from Butler, I believe, and makes flossing very easy, so I don't have to place my fingers in the patient's mouth. I'm essentially flossing from outside the patient's mouth. It makes it much, much easier. And once I get the excess resin cement out of the way, now we're ready to cure all this and remove the cord. Now there's many different techniques on how to seat ceramic restorations. This is my preferred technique, and here are the 3 restorations immediately after they've been bonded in. These are just stained and glazed. For posterior teeth, I just use monochromatic blocks. I want absolute strength for molars, so I'm using Emax, and you have quite a few other options for doing these restorations. Let's move on to some anterior cases. In this particular situation, we have a patient who has a crown on the left upper central incisor, and as you can see, it's much broader in dimension than the tooth immediately next to it. And this patient has had this crown done 2 or 3 times over the last 20 years and is very unhappy with it. And it didn't take that long for me to convince for the patient that we need to close that space and make sure that the restoration and the tooth next to it are equal in proportion, which he ultimately agreed to do. So what I'm going to do here is I'm actually going to take off this crown, make sure it's restorable, and I'm going to fabricate a temporary with my Cerec machine. And what I'm going to do is I'm going to build in an Invisalign attachment, and my wife was also a dentist. We practiced together. She does a lot of Invisalign. I don't have much experience in ortho. She's going to take over and close that diastema in that space until we're ready to restore this permanently. So I removed the pre-existing restoration, modify the preparation, remove any decay that was there in the interproximal, and now we're ready to restore this with a temporary Cerec restoration. In the previous videos, I showed you how we use a laser to retract the tissue. Here's in a clinical example. I'm just going to use some core to displace the tissue from my margins, and I'm going to go ahead and dust it. Again, you can see exactly how long this process takes me. It's just a few seconds, and we want to be able to discern exactly where the margins end and where the tissue starts. So pretty easy and pretty straightforward to capture that. And I'm going to use my Explorer to displace any tissue that's impinging on my margins. Now we're going to capture this with the camera and our optical impressions, and we're going to start designing this. Again, I wanted you to see a clinical view of exactly how this works. We have to do it with the lights turned off, and we're going to place the camera in the patient's mouth. You'll see that light blink or flicker for a split second. That's when it's capturing the optical impression. So as soon as I hold the camera steady, I've captured that, and you saw that. It took no more than 10-12 seconds. And I'm going to capture the rest of the tooth structure on tooth number 8, the right central, because I want to carbon copy this restoration. What I mean by that is I want my contours of my new restoration to be absolutely symmetrical and reflect the morphology of the right central incisor. So there's a margination, and I'm actually going to use the morphology of the tooth next to this preparation to completely replicate and mirror image it. So here I'm using this copy line. This was done with the previous software version 3.8, and the final restoration was done with software version 4.0. So I'm circumscribing everything on the adjacent tooth that I want to mirror and copy onto my prep. That's what you're seeing in this step of the software. I circumscribe it completely and pick up all the contours, the emergence profile, and when we get a proposal, this should be a mirror image. And that's going to still be a little bit broader in dimension than the tooth in question. I'm going to go ahead and modify it to my liking. I'm actually going to shorten the tooth because when we're doing the ortho, we're going to try and apply a little bit of extrusive forces so that the gum tissue comes down with the tooth as the bone is remodeling as well. So with the subsequent set of trays, we're going to move the tooth down, into position, and hopefully the tissue will trail with it. Now I'm going to add the Invisalign button or attachment to the facial of this restoration by using our shape tool. Again, when we started this case, it was with a previous version, so it looks a little bit differently than the first two cases I've introduced you to. So once this is ready, I'm going to go ahead and mill this, and we're going to bond this in, and the PVS impressions are taken for Invisalign trays from here on out. And that whole process took about 8 months to close that space, and we have the exact dimensions that we want. Here's the media post-op of that temporary placed in the patient's mouth with the button that you see on the facial. And here's the occlusal view, and now with ortho we're going to rotate the left lateral into position, and we're going to move the central into position as well. There's the amount of space that we need to close, and we're ready to proceed with the Invisalign treatment. So here's the protocol with Invisalign. You can see how the teeth are positioned. You can see how number 9 is going to be drifting downwards, and the tissue will be trailing along with it, and hopefully will match the zenith for the two centrals. Fast forward to 9 months later. As each tray was fitted to the patient's mouth, number 9 was trimmed on the incisal so we can keep extruding it. So you see that they're not proportional. It's a little bit shorter than the incisal of the adjacent tooth. Now we do our shade matching. I'm going to use feldspathic ceramic here, and we're going to go through the whole process with software version 4.0. I'll have the patient bite down into maximum intercuspation, and I'm going to capture this relationship of the buccal bite so I can relate the upper jaw to the lower jaw. So again, the camera is turned on, and we're in the correct catalog box called the buccal bite. You see in the lower part of the screen, it's highlighted, it's actually enlarged. That's where I'm capturing the optical impression. It's called a buccal bite. So once we capture this, we'll have the patient open their mouths, and we're going to capture the opposing dentition, the lower arch. So at this point, we want to make sure we displace the tongue, and we're going to powder this, and again you can see how quick and easy that process is. And now we're using the camera to capture the incisal edges and the facial profiles of the lower dentition so I can derive my thickness on the palate of the restoration. So once this is done, we're ready to prep off that temporary feldspathic ceramic and plan for final restoration. You'll notice here in the software I'm going to click from buccal to lower jaw. I'm going to turn the camera on, and you're going to see the corresponding Cerec optical impressions to what you saw me do in the patient's mouth. So again, I'm going to hold nice and steady, and as soon as I hold steady, the optical impressions are captured on the right side with a 3D model. I think with anything you're learning for the very first time, it's really good to see repetition. You can see how we systematically approach every case in the same manner. Numb the patient, grab the buccal bite, the upper jaw, lower jaw, but recognize that the software doesn't care what sequence you go in. So some practitioners prefer to capture the prep pictures first, then the opposing, then the buccal bite. It's completely up to you. The software does not care. So here we are removing the feldspathic ceramic that was bonded in, and now I can see my tissue looks much more healthy than it did when I started. I was able to control the zenith by putting it into occlusion or extruding the tooth while we're doing the orthodontic work. And quite honestly, we didn't know if that was going to be successful, but it was worth a try, and we're very happy with how that turned out. So we'll clean up any unsupported enamel. This is the Sonic Flex from Cavo. It's removing all the unsupported ceramic and the enamel lips you may get from your preps. And now we're ready to place or displace the tissue here. I'm going to use a laser just a little bit. I'm very cautious here because I want to make sure I don't do too much damage with the laser, especially in a delicate situation like this where the tissue has already had some recession. So very delicately you want to displace the tissue with the laser here and get the hemostasis that you want. This is the Cerolaser laser. I have a couple of different diode lasers. The Cerolaser one can work when the environment is wet or when you're spraying water. So I also contoured the tissue to my liking for tooth number 8, and I'm going to take the margin down exactly to the gum line where I want tooth number 9, or the margin for the left central incisor to be. Once this is done, we'll clean up the preparation, and we're ready for the optical impressions. With electric handpiece, this whole process and the tissue displacement, the whole process took maybe about 20-25 minutes. What's great with the Cerec machine, every optical impression I take is time-stamped, so I can see exactly how long a procedure took, and I can document it for these video seminars and tutorials and online courses. What I've done is I've taken some opaque resin cement. This is Variolink bleach shade from Ivoclar, and I've opaqued my preparation. I want to hide the darkened root from the root canal therapy. This was previously endodontically treated. And the green that you saw around the gum tissue for tooth number 8, the right central, was Expacil from Kerr, great at hemostasis. Because the last thing you need when you're trying to capture your optical impressions of your margins is any hemorrhaging or any saliva being on your margin and distorting it. So again, I'm going to verify one last time that I've got the tissue completely displaced and nothing is impinging on my margins, and we're ready to take these optical impressions. The isolight's in place. I don't have to worry about the tongue interrupting me, and I don't have to worry about the lips getting in the way because the Optogate's taking care of that. So once again, I'll place the camera. You have crosshairs that'll show you exactly where you're trying to image or the center of your impressions. I'm going to start with the lateral tooth and get a good shot of my preparation. Again, you can clearly see where my margins are. Can't emphasize this enough. I love this about Cerec. That's how I make sure that within seconds I won't have to retake an impression. I see everything very clearly, and there's no worrying about voids or bubbles being on your margins. A huge advantage over PVS. So once we've captured the optical impressions of the opposing and the buccal bite and the preparation, we're going to relate the models to each other. I'm going to show you in a little bit of detail on how involved the process is. It's actually quite easy. We articulate the models together. Now we place the margins, and you can do this very deliberately and very delicately. I generally just lay the margins down, and if there's any areas where I'm having a hard time reading the margins with the software, I'll expand to what's known as the high definition mode. So here you can see clearly a fallen up tooth structure, and I'll go into the manual mode, and now with the high intensity magnification I can really zoom in and fine tune exactly where my margin placement is. This is blown up 25-fold compared to the naked eye, so you can really discern quite a lot of detail in the exact placement of your margins, be very satisfied when the restoration's proposed and milled. So once the margination is complete, I'll proceed to set the path of draw, which is critical in biogeneric. You want to make sure it's in the right orientation, and the path of draw plays a big role for the development of the morphology of the tooth. So we'll set that, and then we'll get the proposal. We're actually going to derive the anatomy from the adjacent tooth. So you can see how number 8, the right central, is intact, and I'm going to ask the software to copy the contours of that tooth and mirror image them. So once I set the path of draw, the very next step is called the reference tooth. This is a biogeneric reference to be exact in the detail. Once we click on that, we choose which select we want the software to copy. It says, would you like to copy this and mirror image it? And I say, absolutely yes. I want to have a nice proposal that mirrors the exact tooth, and we're ready with the proposal from this step. Once the proposal is rendered, we have all those tools available to us where we can position it in the arch form, raise it occlusively, incisively. Here I'm using the position tool. I'm going to line it up perfectly so it's flush to the incisal edge of the adjacent tooth. And I can also use the rotate tool to rotate the restoration clockwise, counterclockwise, and I'm using all my available armamentarium to position this exactly where I want it. Again, it's the control that we love as dentists, to be able to position this exactly how we want it. I'm going to tilt it a little bit palatably. I'm going to rotate it a little bit clockwise. And once I'm done with the position of this restoration, then I'm ready to fine-tune it and use my other tools like the form tool and the scale tool to bulk up certain areas. Again, the blue turquoise color that you see that's perforating through the restoration is a warning to me that under the thickness that I've designated the software to indicate to me that I need to be aware of this, and it might actually perforate or it might actually fracture if I deliver the restoration. So I'll use the form tool and bulk it out, and that way I'm assured that I'm thick enough. And once I've got the contour down, I'm going to go ahead and work on the contact areas. Again, very, very fine control within microns of how thick we want the contact strength, and the color indication tells me how aggressive the contact strength is. So I'll use the smooth tool here, blend everything in, take out any of the ripples, and this restoration's done being designed. It was designed in under 6 or 7 minutes, if I believe that's correct. We'll go ahead and take it to the mill step, the final step, where we can place the restoration in a multi-layer block and mill it. That whole milling time took about 11 minutes, and here's the immediate try-in. And I like to do the final contouring at the delivery step or even at the try-in step. I'm trying to match the incisal edge perfectly to the restoration of the tooth next to it. I'm going to put a little notch in it. I'm going to contour it, make sure I'm very happy with the contour of this restoration, the fit of it. I'm going to check my contacts with the floss here. I'm just taking a tiny little round diamond burr and sculpting it so the little notching that we see over at the mesial corner for the right central is symmetrical to the one I'm placing on the left central incisor. Now with this restoration I actually went ahead and glazed it, but as you can tell from the adjacent teeth, there's not much shine or luster to them. And sometimes I might even bypass the glazing step and just polish these extraorally and deliver them. So you can see the restoration looks pretty dry here, and just a little bit of polishing, a little bit of staining glazing, completely up to you on how far you want to take this. I can develop the exact finish I want onto this restoration. So a little bit of final touch-up work here, and the restoration's ready to be delivered. Now absolutely hemostasis is critical here. I've got the expacial and the gum tissue of the right central incisor. I'm going to go ahead and etch, prime, and dry the primer on this preparation. Apply the bonding agent, thin it out, and it's your choice whether you want to cure it at this point or not. I'm not going to cure this. I'm going to just thin it out, and then I'm going to deliver the restoration with NX3 resin cement loaded into it. I'll place this in the patient's mouth, and I verify that the restoration is seated all the way before I start any tack curing, and I'm going to go ahead and clean up some of the excess resin. And once I'm sure that I've seated it all the way, I'm ready to cure this completely. The worst thing I can do is cure this restoration before it's seated all the way. Now we'll go ahead and tack cure it and slowly start cleaning up the excess resin cement. The easiest time to clean up the resin cement, as mentioned before, is to wait for the gel set stage, and then just literally peels off, and you can pick at it with your Explorer and check the contacts with your floss. Once we're finished with this process and the cleanup, we'll go ahead and cure it. Here's an immediate post-op picture of this restoration done in a single appointment, and the follow-up picture here is a 1-year recall of that same restoration. So really exciting that we were able to do anterior restorations with the Cerec. Here's another fun case that this patient lost tooth number 8, the right central incisor, and the area was grafted, and then an implant was placed, and then 4 months after the implant placement we went ahead and restored the front 4 teeth with the Cerec. All 4 of those teeth are Cerec restorations done in a single appointment, and it was done with the old red cam and the old milling machine. So that was a good overview of some of the anterior work you can do. Here's a lower central anterior. And this patient had a large decay on the lower central incisor that reached the pulp, and she was in a little bit of a discomfort. There's no active infection, and I didn't feel comfortable just placing a direct composite into a cavity that was that large. So what I'm going to do is I'm going to do this procedure in the crown down technique, where I do the crown prep first and send it off to the milling machine, and while that restoration is being milled, I'll leverage that time with doing the root canal. Now generally, if the root canal can be done in a single appointment, if it's warranted and can be accomplished in a single appointment, I'll go ahead and do it. And if it needs multiple appointments, I'll just place the medicament in the canal and come back and restore it at a later time. What I just did there is I took the pre-op optical impressions of that tooth, and what I'm going to use is this technique called the biogeneric copy mode, where I will literally take an impression of the pre-op condition, and then once I'm done with the preparation, I'll take the preparation pictures, and then my final restoration will be an exact duplicate of the pre-existing situation. Really compelling and awesome how that works. So the patient will never complain that the restoration feels bulkier than what they had in their mouth previously, and it's an identical replica of the pre-existing situation. So I've done the crown prep as conservatively as I can. I'm going to go ahead and use a laser to retract the gum tissue. I'm going to go ahead and powder, and if there's any inadvertent gum tissue that's impinging on the margins of my preparation, I'm going to go ahead and displace that with an Explorer. At this point, we're ready to take the optical impressions of the preparation, And most of us who are longtime Cerec users will like to delegate the steps from here on out to the assistant. Because after I capture these optical impressions, I'm starting the root canal therapy. And my assistant's designing the restoration. So on the right-hand side at the bottom of the screen, you see the biocopy lower. Those are my pre-existing pictures of the restoration of the tooth that was intact. Here are the prep pictures. I'm going to go ahead and place the margins. Very easy to do this. Again, we have the high-intensity mode, and we're going to proceed to what's called a copy line. With a copy line after the path of insertion step, here you see it is I'm telling the machine the gray model is the pre-existing condition, and I'm telling the machine I want you to copy the exact contours of that pre-existing case. Here you can see again I'm a little bit too thin on the facial, so I'm just going to gently bulk it out so I have at least 0.5, 0.6 millimeters in thickness. You can see the wear on the incisal edge that I've reproduced in the final restoration as well. So I can transfer all the pre-existing information onto my final restoration and have an exact duplicate. It's really awesome how that works. We'll touch up the contacts approximately, and we're ready to send this off to the milling machine. Small anterior restoration like this probably took about 10 minutes to mill. Here's a different size blocks we can use, and I have multiple milling machines so you can designate which milling machine it goes to. And here's the multi-layer block that I've decided to place this restoration in. Now we'll send that off to the milling machine, and while it's milling, I'm going to go ahead and place the rubber dam and do the root canal therapy. And I'm leveraging the mill time with the prep time. So direct access to this, very simple to reach the apex. I used the apex locator, got to the very tip of the root, and open up the canal and then fill it with the gutta percha. And once that was done, I was ready to deliver the restoration as well. So again, I reverse the sequence. Traditional dentistry calls for doing the root canal first and then sending off the restoration to the milling machine, but I'm going to reverse the sequence. I'm going to do the crown prep first and send it off to the milling machine, and then while that's milling, I'm going to do the root canal. You leverage quite a bit of time here. Now I'll remove the excess gutta percha. Here's a try-in of the restoration. You can see it on the lingual. Its margins fit perfectly. And now that's going to be staining glaze. We got a little bit carried away with the staining glaze on this restoration, and right after I bonded it in, I went ahead and polished off all the excess stain that you saw, the white birch stains on the facial. And here's a recall image of that same tooth a year post-op. So very productive to be able to utilize the Cerec machine to do a root canal of the crown in a single appointment. We can also send our cases to the lab. Here's a case that's actually 2 abutments for an implant bridge. I've actually scanned those in the patient's mouth, and I've digitally sent this information to the lab. And the lab is going to design the framework to ideal contours, and they're going to mill this out of a resin block. Here's acrylic CAD from Ivoclar. They're going to mill the framework, and then the models are printed, or either printed or milled, and the lab can actually check the fit of these the framework and send it back to me. So when the patient comes back, I'll remove the temporary. Here are the abutments in the patient's mouth. I'll try in the metal framework, and this is all done digitally, and then I'm going to send it back to the lab to have the ceramic layered on top. What's great about that is once I scan the abutments, I only pay a bridge fee. I don't pay a fixture level impression fee. I don't pay for custom angled abutments. It dramatically reduces the cost for delivering that restoration. Now, speaking of implant restorations, implant placement, I do everything guided surgery. So here's exactly how the process works. We have a patient who has an edentulous area, and what I want to do is I want to place that implant perfectly centered underneath this prosthesis, which is digitally designed. So I'm going to go ahead and scan the buccal bite. You're familiar with that as well. And once I've captured the buccal bite, I'm going to place the isolite in the patient's mouth. I'm going to capture the opposing, and I'm going to capture the dentulous area. In fact, your assistant can do all this. Very easy to do, especially with the adjunct armamentarium we have here with the isolite. Very easy access. I don't have to worry about the tongue, the lips, or anything else like that. And very easy to capture this. Now, once I scan this area and I design where I want my restoration to go in the dentulous area, I'm going to import that digital file into my cone beam machine, and I'm going to design the implant placement so that's perfectly centered underneath that restoration. What that does for me is when I fabricate the surgical stent, I can actually do the surgery so that the implant finishes and is placed exactly where I had originally digitally planned it. Plus, furthermore, it makes restorative very, very easy. So back to what you're watching clinically here, where you capture the upper impressions, and I'd like for you to see exactly how long it takes for me to do that. And I'm going to also dust the edentulous area here, where the first molar is missing. Once again, I want to show you how readily and easy it is to capture these optical impressions. This is not a definitive restoration, so your team members can absolutely tackle this. Again, as you notice, if my camera is moving, we don't capture any 3D optical impressions on the right side of the screen. Where as long as the camera is moving and it's not held steady, it will not capture it until you hold the camera steady. We use the buccal bite to articulate the models together. And now I'm going to design my desired placement of this restoration. I'll place the margins exactly to the contour that I want. I get that proposal for this tooth, and I like to design this to full contour, which gives me the exact height of the restoration. I can actually use digital abutments to see what kind of stock abutment to order and how much adjusting I might have to do, or alternatively choose to use a custom abutment. So once that's done, the restoration is designed. We're going to export the case into a file called an SSI file. Now this I'm going to save on my network or on a thumb drive and take it over to my Galileo's machine, the cone beam machine. Now before I scan the patient with the Galileo's, I'm going to place this thing called a bite plate. This bite plate has 6 radiographic markers on it, so I can verify that I've done a good job and there's no distortion. And I'm going to line this bite plate with PVS material. When I line it with PVS material, I seat this in the patient's mouth, and the patient is scanned with the bite plate in their mouth. This bite plate is converted to the surgical stent. So what's great is when I get this surgical stent back from CCAT, I know it's going to fit the patient's mouth perfectly as I took the impressions myself clinically. So the patient is now scanned, and here's a 3D scan. On the top left corner is a panoramic view, and the top right corner is a 3D view. And in the lower panels, we have a tangential view, we have a cross-sectional view, which is looking at the patient from straight ahead, and then we have the axial view, which is looking at the patient from above in cross-section. Now I start plotting the nerve, and I do this in front of my patients so they can see exactly what the critical superstructures are here that I need to worry about, or critical anatomy is that I need to worry about. I'd like to place the mental foramen location in the cross-sectional view, and then here in the tangential view I can clearly see the outline of the inferior alveolar nerve canal. Once I've plotted the nerve here, now I can go ahead and choose my CAD-CAM file. Now that same Cerec restoration that I designed, I'm going to import into the Galileo software, and I'm going to incorporate this to my 3D X-ray scan. And this is very simple. I just click on the immediate neighboring teeth and click next and verify that I've done this correctly, and now I just transfer the location of my desired restoration onto my 3D X-ray scan. And now I can actually place the implant perfectly centered underneath this. Here's a verification step where you want to make sure you did this correctly. You can see the Cerec scan overlaying my Galileo scan, and we click on confirm, and now I can start the implant planning. Now this Cerec system and the Galileo system is the only system that no other manufacturer has this. Some manufacturers let you do the design, but you can't mill a surgical stent, or you can't have a surgical stent fabricated from this integration process. This is patented and it's unique to only Cerec and Sirona and the Galileo system. So in the cross-sectional view where my cursor is, you can see how I've got the outline of the tooth, I've got the outline of the nerve, and we can see the concavity, although it's very mild on the lingual part of the mandible. Now I'm going to go ahead and choose my surgical instruments here, or the exact fixture that I want. I'm going to use the Astra for this particular case, and I'm going to drop the implant perfectly centered, or I'm going to place it somewhere near the restoration. Now I'm going to start fine-tuning it so it's perfectly centered. So what you're watching is called the panorama view. I just clicked on the implant align view, and this lets me make the path of draw, or have the whole X-ray rotate around the path of draw of my implant. So here you can see how close I can get to the nerve. There's that concavity on the lingual, and just by rotating a little bit to the buccal, I stay clear of the concavity on the lingual part of the mandible, and I can spin the bone around completely around this implant to make sure that I'm not perforating anything that's super critical here. So I've made this quite simple, but you get the idea of exactly how much control you have over the placement. And now it's time for surgery. And this is a stent that was fabricated by a company called CCAT. As of summer of 2012, we can actually mill these stents, and you can visit the Cerec Doctors website, do a search for the Cerec guide, and see exactly how that works. But this is the surgical stent that is manufactured from the scan that I took and from the biplate that was taken intraorally. I'm going to go ahead and do a tissue punch when I have enough attached gingiva and I have bone completely encasing my implant. I don't need to do any grafting to the threads of the implant. I'll do this flapless. Now this is pretty detailed and you have so many different options. I'll try and keep this as simple as possible. After the design of the implant placement, we get a cookbook back from CCAT that tells us which keys to use. What you see inside the sleeve is called a key for this particular drill for the Astra. You notice I'm using a pumping action. I'm going to make sure there's plenty of irrigation that gets into the bone. I don't necrose the bone or overheat it. And I go through a sequence of drills and keys. Again, this is all nicely mapped out for me in a cookbook manner, and I follow the sequence. And I believe for this implant, a 5.0mm Astra, I had to use a set of 5 drills with specific keys at specific heights. Once I've done the osteotomy creation and I've irrigated the side of the osteotomy and debrided of any extra bone, I'm going to go ahead and deliver the implant through the stent. And what you're seeing here is a carrier that's attached to the implant, and it helps me deliver the implant, and as soon as the carrier touches the top of the stent, now I've completely seated the implant to the appropriate depth. I'm going to disengage the implant carrier and remove the whole appliance, and the surgery is done. And I have no worries about perforating anything that's critical, and most importantly, the implant is placed exactly where my final restoration is going to be delivered. And when it's done perfectly center like that, it's frequently I just use a stock abutment, scan it with my Cerec, and design a Emax that I would seat on top of the abutment and deliver it in the patient's mouth. So there's the exact location, perfectly centered, and we're going to go ahead and place a healing cap. So this was a kind of introductory approach to all the different things you have available to you with your Cerec system. If you intend to purchase one or invest in one, just want to make sure you had a complete grasp of all the different options of treatment you have available to you.